Imagine a patient walk into your clinic complaining about intense throbbing headache right between their eyes. But there is a catch. Every time the patient move their eyes to look around, the pain spike drastically. They think it is an eye problem. If you mistake this for a simple tension headache or an ophthalmic issue, you could completely miss a dangerous infection sitting millimeter away from the brain. By the end of this video, you will not only know exactly which structural abnormality is causing this eye movement pain, but also you shall understand why a routine sinus surgery can accidentally leak brain fluid if you don't know your nasal landmarks. Let's master the lateral wall of the nose. Before we look at the bones, let's understand the lining of the nose. It splits into the three distinct histological neighborhoods. First is vestibule, the entryway where you can physically stick your finger. Because it is exposed to the outside world, it is lined by the tough stratified squamous epithelium. If this area gets inflamed or infected, usually due to staph aureus from the nose picking, we call it nasal vestibulitis. Move deeper into the middle part where the normal breathing happens and the tissue shifts to the ciliated pseudostratified columnar epithelium to warm up and filter the air. But what about the very top, the upper 1/3 part? That's our olfactory zone, featuring a distinct brownish olfactory epithelium. Have you ever wondered why we sniff when we want to enjoy a fragrance? Normal breathing bypasses the top roof area. When we sniff, you have physically altered the fluid dynamics and forces air current upward to hit those smell receptors. So that's the reason. Now let's build the lateral wall of the nose. It looks complicated on CT, but it's just a jigsaw puzzle of the bone. To make it easy, think from the front to back using our memory trick. And the trick is my little ethmoid palatine. We start anteriorly with the ascending process, that is frontonasal process of the maxilla and the medial wall of the maxilla. Right behind it sits a fragile lacrimal bone. Deep to that is a complex maze-like ethmoid bone. Finally, forming the back wall, we have perpendicular plate of palatine bone and the pterygoid process of the sphenoid bone. But write this down in the big bold letter for your board exam. While most of the structure we are about to discuss belong to the ethmoid bone. The remaining one is inferior turbinate. It is an independent, separate bone entirely. It has its own unique attachment to the lateral wall. To truly master the endoscopic sinus surgery or excel in the clinic, you have to look at the lateral wall as a 3-story building. The floor are the turbinates, curved, highly vascular bony projections. The space underneath those floors are meatus, which acts as a main drainage valley for your paranasal sinuses. If you remember this simple rule, you will never get disoriented during the endoscopy. The meatus always sit down and to the outside, inferolateral of its matching turbinate. We start at very top, the superior turbinate and the superior meatus. This is tiny, delicate neighborhood at the back of the nasal roof, and it's like a middle neighbor. It is an anatomical extension of the ethmoid bone. Before we look underneath it, look right above it. There is a small slope pouch called as sphenoethmoidal recess. This is a classic exam favorite because it houses a single massive structure, the opening of the sphenoid sinus. Now drop right beneath the superior turbinate into the superior meatus. These small alveoli contain the drainage ports for the posterior ethmoidal sinus cells. Clinically, remember that when you are treating posterior ethmoiditis or clearing disease here, you are working right against the skull base, just millimeter away from the optic nerve and the internal carotid artery. Now, let's move down to the second floor, the middle turbinate and the middle meatus. This is an absolute workhorse region for the rhinology. The middle turbinate is also the part of the ethmoid bone, and it serves as your North Star landmark during surgery. Keep an eye out for an anatomical variants here. You might encounter a balloon, air-filled concha bullosa, or a paradoxical turbinate, where the bone weirdly curves backward towards the lateral wall, physically crushing the space below it. When you look inside the middle meatus, you enter the osteomeatal complex. This crowded hub is where the vast majority of the sinus diseases happen. It drains the three major structures, the frontal sinus via frontonasal duct, the anterior ethmoidal cell through the Hiatus Semilunaris, and the maxillary sinus through the main ostium tucked deep inside the infundibulum. If a patient presents with the pansinusitis, this congested middle meatus is almost always the structural bottleneck. And finally we reach the ground floor, the inferior turbinate and the inferior meatus. Let's reinforce the fundamental point. Unlike the upper two, the inferior turbinate is a completely separate bone. Because it is packed with the cavernous venous sinusoids, it swells rapidly in response to allergen, causing major nasal obstruction. Underneath it lies the roomy inferior meatus. No paranasal sinuses drains here. Instead, it holds the opening for the nasolacrimal duct, which channels the tear directly from the eye into the nose. Ostium is tucked up high right at the end of the anterior one-third of the meatus canal. It is guarded by the wall of Husner, which act as a one-way check valve. Let's see the final summary matrix so you can screenshot for your ward rounds and the upcoming exams. Remember, the attic sphenoethmoidal recess drains the sphenoid. The top floor, the superior meatus, drains your posterior ethmoids. The busy middle meatus handles the trio, frontal, maxillary, and anterior ethmoid via osteomeatal complex. And the roomy inferior meatus is strictly reserved for the eyes to drain their tears via the nasolacrimal duct. Mastering these specific spaces means you can read CT with confidence and plan FESS approaches with clean, precise orientation. Now we are entering the dangerous territory of the nose. Ethmoid bone forms the roof and the top walls. Its top border is a cibriform plate, which is perforated like a sieve to let smell nerves drop from the brain. Because this bone is paper thin and the roof of the nose is classified as a highly dangerous area. During functional endoscopic sinus surgery, FESS, if a surgeon pushes too high or loses orientation, they can fracture the cibriform plate, causing an immediate clear drip of the brain fluid, a CSF rhinorrhea. Let's link this back to our starting question. Why does ethmoid sinusitis causing excruciating pain when moving the eyes? Look closely at the lateral wall of the ethmoid sinus. It is bounded by the bone called as lamina papyracea. Papyracea means paper thin. On the immediate other side of this tissue paper thin bone lies the orbit and the muscle that moves your eyeball. When the ethmoid sinus is severely inflamed, the heat and the pressure transfer directly to the eye's muscle. Every time the patient looks around, those muscles rub against the inflamed wall, triggering the sharp pain. If you are going to perform sinus surgery, you must memorize the Osteomeatal Complex, OMC, located within the highly crowded middle meatus. Think of Osteomeatal Complex as a central airport hub where the flights from the three major destinations, the frontal sinus via frontonasal duct, the maxillary sinus via infundibulum, and the anterior ethmoidal cell all merge to drain. When a patient has an acute sinusitis, this area gets heavily congested. Anatomically, you will encounter uncinate process, which is a sharp hook-like bone. Right behind it sits a large bubble cell called as Bulla ethmoidalis. A crescent valley between them is a Hiatus semilunaris. During FESS surgery, very first step to widen the blocked sinus is an uncinectomy. surgically resecting that hook-like uncinate process to open the doorway wide and clear the congestion. Let's look at deplumbing. The lateral wall has a dual arterial supply. The heavyweight champion is a spinopalatine artery, a branch of the external carotid system, often targeted in severe nosebleed. But top of the wall is supplied by the anterior ethmoidal artery, which stems from the internal carotid system via the ophthalmic artery. And the superior labial artery supplies the Acarnica cells. On the venous side, the upper pathway track backs through the ophthalmic vein directly into the intracranial cavernous sinus. This is why untreated infection in the upper nasal cavity are incredibly dangerous. They have a direct highway to the brain. Now let's resolve the question we started with. Why did our patient experience intense pain behind the eyes, especially when moving them? As we discovered, the ethmoid sinus is separated from the orbit by a paper-thin lamina papyracea. When that sinus fills with the fluid and inflames, it directly irritates the neighboring eye muscles, turning simple eye movement into the painful ordeal. And remember our structural warning. Always check your coronal CT scan before a FESS procedure to identify the location of the cibriform plate. And look out for the variant air-filled Concha bullosa that could be pretending as a polyp. If you found this breakdown of the lateral nasal wall helpful, hit the subscribe button, drop a comment with a favorite memory trick from this video, and share this with fellow medical colleague. Until next time, keep learning and stay sharp in clinic.